Welcome to Critical Choices, the podcast where we explore ethical challenges shaping emergency medicine today. Brought to you by the Ethics Committee of the American Academy of Emergency Medicine, this podcast delves into critical issues at the intersection of medical ethics and real-world emergency care. I'm Melissa Myers, an associate professor of emergency medicine. And I do need to put a disclaimer that the opinions and assertions expressed in this episode or elsewhere are those of the author, myself, and do not reflect the official policy or position of the Uniformed Services University of Health Sciences or Department of Defense. With me today, I have Dan Mayer. Can you go ahead and tell us a little bit about yourself?
Hi, Melissa. Thank you. My name's Dan Mayer, and I am retired emergency medicine physician. I practiced for 45 years total. The last 27 were in Albany, New York, at Albany Medical College, where I was director of the evidence-based medicine course and practicing emergency physician and teaching emergency medicine residents, as well as other residents, for 27 years. I've been retired for 10 years now and keeping active.
Yes, thank you for being here with us today. Today, we're going to be talking about determining capacity in the emergency department. And I know that I've come back to this several times over the years. And I think every time I come back to it, it's because I had a case where I wasn't sure how to determine capacity and I have to rework my approach. When we're talking about this, one of the things you brought up is you wrote a paper on this in 1990, Refusal of Care and Discharging Difficult Patients from the Emergency Department. What prompted you to write that article?
In about 1989, as I was new faculty at Albany Medical College, and I was asked by ASAP asked me to give two lectures at the annual meeting, one on emergency care of psychiatric patients, and the other one on handling difficult patients in the emergency department, and didn't really give me any guidance on what they meant by difficult patients. So I figured, oh, okay, people who are alcoholics and psychotics. But wait, I'm already talking about psychiatric emergencies. So maybe talking about people who don't want care and who are demanding to be discharged, refusing care. And in preparation for the lecture, I started getting into this whole literature of the refusal of care. And once I had the lecture done, then it was a no-brainer to go and write the paper. I did a lot more research on it, and that led to this paper then.
I think some of us might have slightly more difficulty going from a lecture to a paper, but I'm glad that you wrote this because it gave us a great outline for today. One of the questions I had for you is when I was reading through the paper, it felt like something that could have been written yesterday. Do you feel like there have been a lot of changes in capacity evaluations, or are we still doing things the way we were in 1990?
No, I don't think there's any change. I'm shaking my head yes and no, because on the one hand, maybe we have better tools or maybe we have better understanding. But back then, and it's only 34 years ago, 35 years ago, we understood about capacity, but we were just beginning to separate it from competence. And it wasn't quite as enshrined in in the process of determining whether patients should or shouldn't be allowed to refuse care or, on the converse, even accept care.
Interesting. Do you think that there's been a greater emphasis on autonomy over the last 30 years with doing more capacity determinations or not?
Yes, I think that this has become ingrained in our culture and in the emergency medicine literature. There have been probably about half a dozen papers written since then about refusal of care and the various ways to deal with patients who refuse care.
Interesting. Yeah, I was doing some uh, ethics reading recently with a couple of papers from the 1950s, and I will say certainly since the 50s we do things very differently. There was nothing in there about refusal of care. Quite a
There
bit
was
about sedating patients.
Yes, that's true. Although the first case, the first legal case of this, and the one that sort of enshrined, I'm looking for the date of it, that enshrined the idea of patient autonomy was Schlorendorf versus I think it was the New York Medical Board or something like that, which was from the early 1900s. And I'm sorry, I should have the date right here on the top of my list of references, and for some reason it must have gotten put to the back. But it's basically
Yeah,
goes back that far that the whole concept of patients being able to refuse care that they feel for whatever reason is not in their best interest.
and I'm certainly a product of the modern medical system, so I had it ingrained in me during medical school and residency that We absolutely cannot force patients to stay unless, and this is what we're going to talk about today, they don't have the ability to understand the risks of the decision they're making, because that's when we have to balance out autonomy and beneficence. When can't I let this patient go because they don't know the decision they're making and could cause harm without understanding? So you mentioned capacity and competency. Can you tell us what those are and what the differences are between them?
So capacity is the ability to make a decision and to have balanced all of the inputs, all of the factors that led to that decision to come to something that is appropriate for the patient. And it's the patient's ability to manipulate that information.
And how is that different from competency? You mentioned that as being a legal determination.
Yes, competency is something that only a court can decide. And it has to do with whether you're able to handle your business matters or your financial matters or even your daily living matters. You might be placed in a mental hospital if you can't take care of your own daily activities because you're incompetent. And again, that is a legal decision. Psychiatrists, and I'm maybe getting this a little bit mixed up, but basically psychiatrists make that decision when they decide to involuntarily to the hospital, but that only holds for a certain set period of time. I think in New York State it's 72 hours, after which a more formal decision has to be made on the competency of the patient to be able to make their own decisions.
Makes sense. I'm certainly not a lawyer. I always separate it into my head as capacity is the temporary one that I do in the ED, and competency is the permanent one that happens in a courtroom somewhere.
Yeah. The take-home message is never ask a psychiatrist to determine the competency of a patient in the ED. It doesn't happen. We make the decision of whether a patient is safe to send out for psychotic patients and people with psychiatric illnesses. And then the psychiatrist can determine later whether that extends to this competency issue, which they then have to get a court order for. But we're the ones who do the capacity determination. Sometimes it is hard, and sometimes it requires either a psychiatrist to come and help because, frankly, they have more time to sit and talk to the patient than we do. And some of these conversations could take a long time. And then it is appropriate to ask a psychiatrist to come down. But remember, always ask them to do a capacity assessment. Those are the magic words.
That makes sense.
Mhm.
So almost always I know when I go to do a capacity eval, it's because the patient is declining whatever treatment I'm offering them, anything from antibiotics to hospitalization. I don't think most of us do capacity evaluations if the patient agrees with the treatment plan. The one exception to that being informed consent for a surgery or some procedure with morbidity associated with it. When we go to do the capacity, as you mentioned, we often have very limited time constraints and limited information. When we wrote an article, so you and I wrote an article together for Common Sense that should have come out by the time this podcast does, and we talked about doing these limited time capacity evaluations. And you gave us a framework. Can you talk me through that?
Yeah, one of the fascinating things that happened to me while I was writing this paper was that I got in touch with a guy named Paul Applebaum. And at that time, Paul Applebaum, who's a psychologist, I believe, was writing about capacity. And so he was naturally a person that I would be in touch with about this paper. And he said, I've just come up with a new capacity framework. And if you'd like to use that in your paper, you have my permission, which I thought was awesome. Yes, I was a nobody assistant professor at the time, and he was a full professor at one of the Ivies. But anyway, so he allowed me to use this, and I put it in my paper. And basically, it's a four-step process to determine whether the patient is able to manipulate ideas and concepts and thoughts and put those all together with a rational, and rational means for the patient, not necessarily for us, but for the patient, a rational thought process to come to the final decision.
Yeah, I'm so glad you brought that up because I think sometimes without intending it to, our capacity eval may default to do they agree with me? And if they don't, then obviously they don't have capacity. And we're going to talk about a couple of cases in a minute where the patient made a choice that was not the medical recommendation for sure, but it had an internal logic and the patient was making it in accordance with their values and so was demonstrating capacity.
Mhm.
Um, So I've got a copy of this framework in front of me, and I'm just going to go through a couple of these steps because I think it's probably 4 to 5 questions for most patients, and I think it's a great approach. So you have the four necessary components for someone to have capacity are ability to render a choice, so they have to be able to tell you what their choice is, the ability to understand relevant information, ability to appreciate the situation and its consequences, and ability for rational manipulation of information. So I think if I was going to break that down, the tricky one is that ability to understand relevant information. How have you assessed for that when you're doing capacity evals?
And this does take time. There's no question about it. But basically I will give the patient what their condition is, what my recommended treatment or testing, whatever the next step is that they're refusing. What are the benefits? What are the potential benefits that I see happening from that? Are there any possible risks or discomforts, and what are they? And you have to be honest about that. And then what other options might there be? This means not necessarily the best option, but what other reasonable options do I see as a physician that might be okay in that process? And then what are the benefits and the risks of not treating, of not getting treatment? And then I ask the patient to basically tell me that again in their own words.
Yeah, I think that's the important part, them giving it back to you. And that leads us into the ability to appreciate the situation. So, really, I think this kind of boils down to, do you understand what's happening? Do you understand the decision that you're making and the risks and benefits of that decision? And finally, we already talked about this, but there is that internal logic, which
Right.
doesn't have to mean they agree with us. It just has to mean there's some sort of underlying logic holding it all together. Um, we have these great questions, and I think you and I both know that there's still tons of times that you go to do a capacity eval and you're just not sure. I think of a patient I had years ago, very nice woman. She had COPD. She was young. She was in her 40s or 50s. She had the alpha trypsin deficiency and was probably actively dying in the ED. Her stats were in the 70s. We had her on BiPAP. It was very clear with us that not only did she not want to be intubated, she did not want to be admitted, wanted to leave. And so we're going around and I understand, like, you're repeating this back to me. You sound very reasonable. She was very clear with me that her kind of value was I want to die at home where my kids are. And that we went back and forth. It's one of the very few times that I've called in a second physician because I was like, she's checking all the boxes, but this woman's going to die if I discharge her. We actually had palliative care come down and assist us with doing a second eval. And then we discharged her. She met the criteria to make that decision. But what do you think about how do you navigate these gray areas where maybe they're checking the boxes and you're still not sure?
So you mentioned that she had kids. And
Mm-hmm.
the first thing that I would do in that situation when I'm very frustrated because I feel like this person needs to be admitted, they can probably be managed maybe with non-invasive breathing, but might need to be intubated. All right, intubation is a pretty invasive procedure, but now she's saying she wants to die with her kids. So let's talk to the kids and see where they are in mom's decision. Because on the one hand, mom's decision may be reasonable. She's got a terminal illness. She's getting worse and worse from that illness. She's lived through all of the complications and everything. And this may be her time to go. And yes, it would be very humane of us to let her die at home peacefully and in the company of her family and doing all the things that make her comfortable, which is giving morphine to reduce the anxiety from being short of breath and making sure that she has adequate oxygenation, but not invasive, and whatever else might help. And I'm not a palliative care physician, so I don't know a lot of these details. But again, having palliative care involved is obviously important there.
Yeah, it was certainly a difficult case. We deaf consultants involved there. I thought about that case a lot over the years, and I think the longer that I'm out of training, the more comfortable I am with that decision to discharge because I more and more have recognized the importance of the patient's values over mine, which seems
Yeah.
very obvious and I think is a little harder to actually do than I would like it to be. That said, in that particular case, I got very lucky that the palliative care doc was actually in hospital. I usually work nights, and so majority of the time they wouldn't have been available. It's great to have consultants. They're not always around. I'm taking some graduate school classes on ethics. I recently took one on ethics consultation, and they had us sit around and play out an ethics consult. And the case that they picked was an ED patient who wanted to be discharged because she didn't want antibiotics. She wanted to go home and receive healing through her community. It was very interesting to me because no one else in this simulation was an emergency medicine or emergency medicine adjacent. We had a couple social workers, a neonatologist, and an ethicist. I brought up, I was like, I would not call an ethics consult for this. This patient very clearly has capacity. The woman wants to go home. I'm not going to make her stay in the hospital. And it was derailed the whole simulation because I was playing the ER doc. And I was like, but I don't want to call a consult. I don't feel like I need one. She was like, you have to call. So that said, what do you think is the role for the ethics committee or for a psychiatry team to assist us with these determinations?
Yeah, and that's a good question because, and then my question, of course, is was she going to die without antibiotics? Because in pre-antibiotic era, people with presumed pneumococcal pneumonia have a 30% mortality rate, but that doesn't mean you're going to die. It means that you might die. And as long as she understood that and was willing to accept it and essentially going through all of the processes of the capacity determination, I think that it's very reasonable not to get an ethics consult. So the example that I have was a middle-aged man who came in with chest pain, very kind of non-specific chest pain, had non-specific changes on his EKG, a little troponin bump, and I wanted to admit him, and he insisted on wanting to go home. He met all the qualifications of capacity, and I just felt uncomfortable saying that he was okay to go home. And it was the daytime, and ethics were around, and they were fairly new and wanted to get as many consults as they could get. So I'm not sure how much that fed into my decision, but I did get an ethics consult. They talked to him for about an hour or so, and at the end of the conversation, he agreed to stay and be monitored and have the cardiologist see him and do whatever they needed to do. But it's only like a handful of times that I've had to that I have called an ethics consult.
I actually never have because I've never worked at a facility that had the ability for a real-time ethics consult.
It
It would have
may
been really nice to have a few times for sure.
And it may have helped that we had such an active bioethics program beginning in the late 80s that it was available and freely available, easily available 24 hours a day. They would come in at night if you needed them. So the fact that it was easy to call them may have had something to do with me calling even a handful of times.
What about psychiatry? Have you found a role for a psychiatry consultation?
I have, and I'm trying to remember the case, but there was a case of it was a psychotic patient who on the surface made sense and was able to go through most of the capacity thing, but there was something that he wasn't quite connecting. And I came down because it was a busy shift. I called psych and they came down to see him. And I said specifically, I'm sorry, there's something bugging me about this guy. I think he might not have capacity, but I can't tell for sure. Can you come down and help me? And they did. And in fact, the first thing the psych consult said was, I'm so glad you told me that you wanted a capacity assessment. We're more than happy to do those. We love doing those, but we're always asked to do a competency determination, and we don't do that. And I said, yeah, I know. And obviously it was somebody I was very friendly with anyway, and then he went and did the capacity assessment and came out after an hour and said, this guy does not have capacity.
Yeah.
We're gonna have to admit him to the psych ward. And he was a risk, a danger to himself or others. Particularly in this case, it was a danger of suicidal actions that I couldn't uncover, but there was enough about what he was saying and how he was saying it that made me uncomfortable. So that was that way. And I think you have to go with your gut on those when the patient is making more or less making sense, but there's something about what they're saying that isn't quite right. Get some help. And again, remember to say capacity assessment.
Not competency. That
Not
makes perfect sense to me. I work with medical students a lot these days, and I always tell them if it doesn't seem right, stop and think about it and maybe call for help. Don't just keep going. So yeah, thank you so much. Now, so far we've been talking mostly about cases, besides the one you actually just mentioned, where we ended up deciding, yes, this patient has capacity, although they're not agreeing with my treatment plan. But that is definitely not all of the cases. And sometimes, like we talked about at the beginning, we need to prioritize beneficence over autonomy. The patient cannot make an autonomous decision. So let's talk about one of those really tricky cases. You mentioned early on in your practice, you had a man who was very intoxicated and was leaving your emergency department against medical advice, was going to drive. How did you approach that?
And I don't remember what he was in the emergency department for. It was something relatively minor and he wasn't particularly sick. And I was fairly new in emergency medicine at the time. I'd only been practicing for 2 or 3 years. And I didn't really understand all of the elements of capacity at the time, but he seemed to make sense. But the nurse said, Dan, he's going to drive. Maybe we should call the police. And I went up and talked to him and said, you're quite intoxicated, and it's definitely not a good idea to drive. The fact that you had this little laceration was something minor that if you don't want to get it fixed, fine, but I can't let you go and drive. And he said, I don't care. I'm going to drive anyway. And he turned around to head for the door, and I noticed his car keys sticking out of his back pocket, and I just grabbed him. And he couldn't drive, and he didn't. What was my backup plan? I have to admit that my adrenaline was so high at the time. I don't know if I had a backup plan, but it would have been to notify the police that this intoxicated man had just left and we had no way to hold him. We couldn't physically restrain him, and we were not willing to take that risk for ourselves. But he went out and drove in his car obviously intoxicated. And that would have been the backup plan. And have I done that in since then? Yes, there have been 1 or 2 times when patients who were highly intoxicated left and were seen getting into a car by the valets or the guards who notified us, and we notified the police department who went looking for them.
That raises the whole issue of being a mandated reporter, which I'm going to duck for right now, but I do plan to do a future episode on because that is worthy of a full discussion. Yeah, and I was thinking of a case I had just 2 weeks ago where I had a patient brought in by his spouse, and the patient's chief complaint was chest pain. And I go in there and I'm talking to him, and the wife's, can you talk outside the room? And she's like, yeah, he's not here for chest pain. He's here because he thinks I have a bomb in my purse. He's becoming increasingly paranoid. I don't know what to do. So I'm like, man, you don't have a bomb, right? She's like, no, absolutely no. I'm like, great. And I go back in and I talk to this guy, and he's going on and on about his chest pain. And as we're talking, he's also telling me that he's very concerned that the FBI is following him. And do I have a camera in the wall? And so I'm like, yeah, this isn't going great. And I actually went through capacity eval on him, and he absolutely did not understand what was happening. There was no internal logic. And we did hold him. Unfortunately, we had to sedate him to hold him, but he presented a very clear threat to himself. So we, in that particular case, felt that he didn't have autonomy. Now, I want to take a little bit of a left turn before we go into our last case discussion and talk about AMA forms, because I think we often lump AMA forms together with capacity. They're very different, and I think that AMA forms deserve their own little discussion. So AMA form or against medical advice form, very commonly found in the emergency department. We ask patients to sign them when they're leaving against medical advice. Now, I was always taught in residency that these forms don't really offer a lot of legal protection. What's your opinion on the AMA form and what it does and doesn't do for us?
So my opinion is pretty much, I agree with you that it doesn't offer, in and of itself, does not offer legal protection. But what it does is it gives you the ability to write down in clear English language that normal people with a fifth grade education can understand the elements of capacity. And we created a form after I wrote this paper. We created a form, an AMA form that allowed us to do this. It had 6 or 7 elements, and I apologize. I wrote to my department to see if they still had those old forms around or what they were using now, and I haven't heard back from them. But we used that to then document what we had told the patient and then ask the patient to read it back to us. Because even though we went through this whole process with them already to determine they had capacity to refuse care and they seemed to check all the boxes, I wanted to give them one more chance. And so I look at it as a form of patient education. And then I do my separate documentation, which is that I talked to the patient. We determined they had capacity. I went through the whole list, and they signed the AMA form after reading it out loud to me and saying that they agreed with it and understood it. and the AMA form becomes part of the record so that what I told them is there for posterity, and a copy goes home with them so that they can use it to determine whether they want to come back. Because the last thing that I always say to people who sign out against medical advice is, should you need to come back, want to come back, please do. We will not hold this against you. This is not a stain on you. This is not something that we're going to punish you for. We will treat you regardless of the fact that you signed this AMA form, but please come back if you don't feel any better, if you feel worse, or if you just feel like you made the wrong decision.
Yeah, and I think once you said that, I do occasionally use AMA forms just as a way to communicate. I am so worried about you that I'm going to have you sign this form. I'm not mad. I'd love to have you come back. That would be my ideal, would be you come back. But I am really worried about you. And every once in a while, someone looks at the form and they're like, you're this worried. I'm like, dude, you might die. I would like you to sign this form. And sometimes that's just a way to communicate that concern and have another discussion.
Yeah, and part of the AMA form is risks. And one of the risks I always put in was this might lead to death. You might die from this. And the old AMA forms, which is where you were taught from, were a paragraph of more or less somewhat legal language that the patient never was able to read or understand and would sign. And we had this hallucination in our minds that this actually did protect us from
Hmm.
some. And I think that's where that whole teaching line came from. And by changing the AMA form and making it more adaptable as a patient education tool, as well as documentation of what the conversation really was about, should change that conversation, should change that whole idea that it's not worth anything. It does
Yeah.
take a little longer to fill out. And yeah, you have to have pretty good handwriting. Unless you, I guess in the EHR era, you can just build it into your medical record and just type it in. So
Probably. I don't handwrite a lot anymore, unfortunately. But that
I
that
had
sounds
good,
like such
I
a great
had good,
approach. Hmm.
I had good handwriting. So that was,
Yeah. And it kind of avoids that thing that I'm always worried about when a patient is leaving AMA, that they're going to be thinking I'm mad at them or don't want them to come back, which is the farthest thing from my mind. All right. So to close this up, we're gonna go through a case. This is mine from a few years ago with some details changed. I was working at a really small rural emergency department. So the nearest cath facility is a good 90 minutes away. And this patient came in. He was clearly having an occlusive myocardial infarction, high sensitivity trope come back at 1200, ischemic changes on the EKG. No doubt on the diagnosis. And I go in and I tell him, you're having a heart attack. We have to transfer you to the big hospital. And the guy says, no. Okay, that was not how I thought that conversation was going to go. How would you approach that?
go through the capacity assessment and say you realize what you have and that this is not just a possible diagnosis, this is a definitive diagnosis. And there's a very good chance you might die, and an even stronger chance that if you do not die, you'll be left with such severe heart damage that you may be disabled for the rest of your life. Why do you want to take that chance?
Yeah, and so in this particular case, I asked the patient, why do you not want me to transfer you? Help me understand what's happening here. I just told you you could die. And explained to me that he was unhoused, he was living out of his car, and his car was at the truck stop right next to the hospital. And so he told me, if you transfer me, my car's going to get stolen. And then I'm not going to have any transport. I'm not going to have any way to get around. I'm going to lose my job. It is worth this risk of dying to move my car. Once we went back and forth on this, and ultimately I discharged him and he moved his car and he came back, which made me very uncomfortable, but I was happy that he came back. But it really illustrated to me that importance of figuring out the patient's underlying logic. What a really interesting point from that case for me was I had several young staff members with me who felt very strongly that this patient was suicidal because he was denying transfer. And have you had that come up where a patient is declining an intervention and staff members are concerned this could be a suicidal intention?
It is definitely one of the things that's always in the back of my mind when I'm dealing with those kind of situations, especially when there's a very clear-cut diagnosis that is very likely to be life-threatening, life or What can I say? Most of the time, it's not. The vast majority of the time, it's not. It's so unusual for somebody to choose that method of suicide. But people are depressed and maybe, I don't know if pseudo-suicidal is a good term to use, but where they're depressed to the point where they feel that they don't want to, it's not worth, their life isn't worth living anymore. And so if they get taken by this disease, it's no big deal. And this might be a good way to go. And again, if somebody is refusing, then you do have to go into the details of why they are and what made them make that choice. And that hopefully should come out.
Yeah, that makes perfect sense. And that was essentially my approach as well in that case was he's not suicidal. He's very clearly explaining to us what his reasoning is, and it makes sense. And he has capacity. So that kind of takes us to the end. What last points do you want to leave our listeners with on capacity determinations in the emergency department?
I think probably the best advice I could give in terms, since we've already talked about when to do it and how to do it, is don't be afraid of doing it. It seems like a lot. It seems like a lot to go through. But when you think about your family, it's the way they would want them to be approached. And that if they're making a bad decision and you don't know about it, you'd hope that the physician, emergency medicine or other, would go through this process with them and determine that they had the capacity to make that decision. So don't be frightened of it. Do look at the four elements, and I do recommend that you incorporate them into your AMA forms so that they do become patient education forms. And yes, I disagree that they don't provide legal protection. I think they do. If you've gone through this much of an effort, then it would be very unusual that you would not be protected legally. So
Perfect.
I think
Makes
that's
sense to
about
me.
it.
Thank you so much for joining me, Dan. This has been Critical Choices, and a podcast from the Ethics Committee of the American Academy of Emergency Medicine. Please join us for our next episode when we'll be talking about the military response to humanitarian disasters.